When patients develop ILD on therapy and they're in a later line stage for their cancer, the question is always, once the ILD resolves, should we retreat those patients with the same agents, which might be their last or best option at this point in time from the cancer diagnosis? So that is a critical point which needs to be really addressed in a very individual patient-based situation. There are some reports about re-exposing patients who had serious complications with immune checkpoint inhibitors when they have a highly immunogenic, highly immune therapy sensitive tumor. So that has been done. And it's really kind of gauging the potential benefit of treatment versus the side effects and the risk of making a pre-existing ILD experience even worse, because ILD is a serious complication and can lead to death. And now for ADCs, for instance, that are also being used, at least in GI cancers, in a later line setting. Again, there is a risk-benefit evaluation that needs to happen. So far, I have not re-exposed patients to ADCs when they develop at least a grade 2 ILD. I would like to see more data on that before I would allow this move forward. When we talk about management of ILD on ADCs, for instance, I discontinue the agent. I do not believe that re-exposing with a lower dose would put patients at a lower risk, because there's not a clear dose effect relationship. This might just be a reaction, sometimes immune related reaction, sometimes an inflammatory reaction induced by these ADCs, which might be independent about the actual dose use. I would not just use a dose reduction and then continue therapy. In my institution, I'm the one who takes care of patients with ILD. I initiate the diagnostic workup, and I would make a decision whether or not to hospitalize patients, for instance, or keep them treated on an outpatient basis. This mainly depends on how much, whether they have oxygen requirements and how aggressive their symptomatology is. So I normally discontinue the agent that I think caused the ILD. Then, depending on the severity, anything above grade 2, I would definitely start glucocorticosteroids and monitor patients closely. And if they deteriorate in their performance status, they need oxygen, for instance, then I normally hospitalize these patients. When we discontinue the causative agent, a lot of patients actually do improve, but it might take time. And this is mainly related also to the fact that the antibody drug conjugate antibodies have a longer half-life. I mean, the biologic half-life of these drugs is anywhere between 3 to 6 weeks. So we cannot expect to have dramatic changes within a very short time when we discontinue these agents. It's different with small molecules, for instance, erlotinib, for instance, or conventional chemotherapy like gemcitabine, where the shorter half-life might actually contribute to a faster resolution. Then, of course, there are some, it's not just the drug that causes the ILD, but it's also the induced immunologic reaction, which can actually be delayed, actually. And actually, we have some patients where the therapy was already stopped and they developed delayed ILD that has been reported. So the critical issue is here to monitor patients very closely over time and do not expect that everything will, be reversible right away when we discontinue the agent. Now, the other point is, depending on the degree of the inflammation, there might be some long-term scarring effects that we see in the lung parenchyma, so that the lung function might actually be compromised to some degree on a permanent basis. This really depends on how much of the lung was affected with how much of inflammation. Considering the management or differences between cancers and the management of ILD, I don't think there is a difference between cancers. I mean, we are facing the same, side effect of these agents, ILD or pneumonitis or interstitial pneumonitis, whatever you might call it. And I don't think the management should be different between different cancers. When we talk about drugs that can induce ILD, it's across the board. It's not just anti-neoplastic agents, also antibiotics, for instance, amiodarone, which is being used as antiarrhythmic drugs in cardiology, etc. People need to be aware of ILD can be induced by various agents, and it will be very important to really see what drugs patients are on, because they're not just on chemotherapy and ADCs and whatever targeted agents we talk about, but also other agents that could potentially cause ILD. And there's the suspicion, of course, that if you have several agents that potentially can cause ILD, they might add up and increase the risk for patients. So I believe, creating awareness for ILD, the side effects of various different drug classes, I think is very important. ILD is a potentially serious complication of some of the medications we use to treat cancer and other agents, other non-cancer related agents. It is a side effect that can actually lead to some degree of mortality, and something that we definitely want to avoid in our patients when we treat them for their cancer. The COVID epidemic right now has created more awareness for pulmonary dysfunction, the use of CT scans to identify infiltrates, interstitial infiltrates. And I believe that we need to tease this out, use this time to create awareness for lung function issues that patients might have with various cancers on therapy, and really facing the idea that we need to tease out and we have a differential diagnosis between infectious complications and drug-related toxicities. So we need to create a higher awareness of how to interpret the clinical findings we see on patients and the imaging findings we see on scans. Other clinicians should be aware of ILD, should use the kind of diagnosis as part of their differential when they interrogate patients, when they investigate patients, and try to explain symptomatology that patients come up with.